So welcome to those who just joined us. We're just going to give it a couple more minutes for others to join before we get started. Okay, well, I think we'll get going here. Hi, everyone. My name is Fiona Lewis, and I'm the Patient Support Liaison for AMAC. I'm pleased to welcome you to this webinar. And as you may know, AMAC is a leading funder of research into bone marrow failure diseases in Canada, and invite you to visit our website to find out more about our services across the country. So your line will be muted during today's presentation, but you're welcome to type any questions you have into the Q&A feature, which you'll see if you hover your mouse over the bottom of your screen, it will pop up. And you can type your question in there and we'll either handle them during the presentation or at the end, depending on what the question is. And if we have time at the end, we'll also unmute the lines so you can just ask your question verbally if you prefer. So I'm pleased to introduce Dr. Christou to present today's webinar entitled Research Priorities in Myelodysplastic Syndromes, a survey of Canadian patients, caregivers, and clinicians. Dr. Christou is a hematologist and member of the leukemia program at the Ottawa Hospital. She is a graduate of Queen's University School of Medicine and holds a Master of Science degree in biochemistry from the University of Ottawa. She completed residency training in internal medicine and hematology at the University of Ottawa, followed by a subspecialty fellowship in leukemia and stem cell transplant. She recently completed a Master of Science degree in epidemiology and public health. Dr. Christou's research interests are in methods for engaging patients in research and patient-centered care delivery in the field of hematologic malignancies. So with that, I'll turn it over to her to begin the webinar. Thank you, Dr. Christou.
Thanks, Fiona, for the introduction. Hi, everyone. So a disclaimer, this is my first time doing one of these webinars. So if I seem like a total amateur, it's because I really am. As Fiona said, as Fiona said, today we're going to be sharing the results of a survey of patients, caregivers, and clinicians, all of whom are in one way or another affected by MDS or myelodysplastic syndromes. And this work was done in collaboration with AMAC. And so this is really a very appropriate forum to be sharing the work with everyone. So the main problem that we are trying to address by engaging patients in deciding what the research agenda should be is that several studies have shown that there's actually a mismatch between what research scientists are conducting and what people living with various health conditions, including MDS, need. And this was, most of the work on this was done in actually rheumatoid and osteoarthritis, where there's clearly very different expectations or interests between what patients want to find out and what the researchers are doing. And when research doesn't address the needs of the population it's meant to serve, obviously that means that the findings of research are not used. So that's a waste of resources because it costs a lot of money, time, brain power, and that's on both the part of the researchers as well as the participants who are often patients. It also means that there is a persistence of the unmet needs, right? So people are always waiting for the same needs to be addressed and they're not being addressed. And that in turn leads to a breakdown of trust in research institutions. And I think we saw an example of how mistrust between the public and research institutions can really lead to a lot of unrest, for example, during the pandemic. So it's important to try our best to always keep as much as possible the needs and the research in sync with each other. And part of the solution, which there's more and more recognition of, is to actually include people who live with the various health conditions, their caregivers, in identifying and prioritizing research questions. And that includes both their caregivers in a personal sense, their friends, their family, who help care for them or who are affected when their loved one is living with a health condition, and also their medical team. So frontline clinicians, physicians, nurses, pharmacists, physiotherapists, whoever it is that is involved in directly treating and caring for patients. And the reason for that is that when people come with a question, they don't go and ask a researcher who's tucked away somewhere. They ask their family, their friends, they ask the internet, but they also ask their physicians and nurses and their kind of multidisciplinary healthcare team, we hope. And then why this process is thought to be part of the solution is then that these resultant research questions that people have come up with will have a real impact on the lives of people living with whatever condition it is. And that in turn both improves the utilization of research findings, but also enriches the field as a whole so that you have a well-rounded field. So obviously I'm talking to you guys, you're the living experts in MDS, but I'm gonna just kind of remind everyone, just in case there are people who are not directly affected by MDS with us. It's a group of hematologic malignancies that are characterized basically by funny looking cells or dysplasia in the bone marrow and low blood counts. And we know that it carries a very high rate of both morbidity, which means, feeling of unwellness and complications, and mortality. And we're very fortunate that in the last, 12, 13 years or so, we've had advances in life lengthening treatments, but ultimately curative therapy remains a stem cell transplant, and majority of patients affected by MDS are not actually candidates for this curative treatment. So the care for MDS consists of frequent monitoring, lots of bone marrows and disease restaging, blood transfusions, various supporting medication, and treatments that aim to slow down the progression or the advance of MDS. And this care is very complicated. There's lots of moving parts. People need to often get care in different places by different teams. And what's important is that we need a team approach. And most of the research in MDS is focused on things like the genetics of MDS and the new molecules in MDS and new treatments, which is obviously very, very important. And I just said that that landscape is changing and has changed a lot in the last 12 years or so and continues to be. So that is not to take away from the importance of what research is being done. However, there are many other issues that are very much under studies. For example, we transfuse people based on some guidelines that are, taken from other conditions. We kind of try to guess people's symptoms. There's no personalization of transfusion practice. When people come to me as a clinician, I want to tell them, well, we can do this or we can do that. And they often say, well, what's life going to be like on option A and option B? And although I can tell them what my experience is by watching other patients of mine go through, various treatments, we don't compare treatments based on quality of life outcomes. We often compare them based on things that are still important, but don't encompass the whole thing, like, how long people live, which again is important, how their marrow responds, but we're not telling them or not able to tell them how their quality of life is going to be different. Lots of people ask about fatigue. Even when you tell me my counts are good, how come I'm so fatigued? The best I can do is put together everything we know and give a guess, but there's no research into what we can do to improve that. Things like what to do with excess iron, how to even best communicate about MDS. And one of the things that struck me the most when I was a trainee starting in the clinic is that actually MDS is probably, if not the hardest, certainly one of the hardest conditions to talk to patients about. And that's because there's such a wide variety of MDSs, if you will. One person's MDS does not look like or act like another. And it's very hard to find the exact balance of how to explain truly and clearly what MDS is and what can happen with MDS, but also, make it appropriate to the stage or the point in time that people are in. Another thing that patients always come to me and their families is, what can I eat? Should I exercise? How much sleep should I get? What can I do to improve my health? And there's not a lot of research, if any at all, into that. How do we prevent MDS? People want to know how, to protect their loved ones, how to spread awareness about it. And those are things that, as humans, we want to take control. We want to have that agency in our own care. And then one other thing is optimal care delivery, which means for people living in different places, in different types of communities with different needs, how do we best deliver care for MDS that is compassionate, that is comprehensive, and that is high quality, given that there's so much variability. And these are just some of the issues that are understudied. These are some of the issues that I hear from people day in and day out in the clinic. And when you try to look for the answers in the literature, you don't find it. So what is this James Lind Alliance approach, which we use to try and get feedback from other fellow clinicians, as well as people living with MDS and their loved ones? So this is an approach that is pioneered by an organization called the James Lind Alliance. It was founded in 2004 in the United Kingdom. And they basically came up with this new method for getting people, lay people and clinicians to participate in deciding what research priorities should be and how to order them. So it's developed a really nice method that depends on things called priority setting partnerships. And those are the cornerstone. So basically people like myself work with organizations like AMAC, for example, and others, as well as professional organizations We have a group of people, usually anywhere from like, I don't know, 5 to 10, form a steering committee, decide on how we're going to go about following the steps of JLA, which I will outline in a minute. And then from there, we kind of reach out to other stakeholders, other organizations, other clinicians, and kind of go from there. And the important thing is non-clinicians, so researchers who don't work in the clinic with people, are not able to submit any of their priorities. And the reason is that those are usually the scientists of various specialties who are already deciding on the research agenda. They are already the ones who are deciding what to research and how to research it. And the point of this exercise is to actually add in another perspective. So I want you to kind of ignore most of this and just sort of focus on some of the big things. So the first step after, I told you that we would form a steering group, and that's what we did. I approached AMAC, and that's what we did. We decided that we would work together to do this. Then you create usually surveys. And now, obviously, with the internet, they're mostly web-based, although there's many pros and cons, but it doesn't have to be web-based, to create a survey with questions and actually get that on. And it says gathering questions because in this case, we're not trying to get your responses, we're trying to get people's questions for researchers. So what do you want research to answer? And then you process them. And this is a pretty intensive process. You have to go through all the answers that people submitted. You have to figure out, okay, what is the question they're asking? They're often not framed like a research question, which is totally fine because we don't expect people to be researchers. But you really want to kind of what we call code. So we want to look for what is the information? What are people trying to tell us? We have to kind of categorize them, and then we have to start to create properly formulated research questions from that information. We have to go look in the literature and see, has anyone published something about this? Do we know the answer for sure? Do we need more research? And obviously, only if we still need more research can we then add it on to the next round. Because if we already know the answer, then maybe the problem isn't that we need to research it more. The problem is we need to do what the research says, for example. And then there's a part where you do an interim priority setting. So you take a long list of research questions and you kind of try and get the groups of clinicians, the groups of patients to rank them so that you end up with like a 30 to 40 or so questions, and those are your top ones. And then you carry them forward to this final workshop, which pre-COVID was almost always in person with a few exceptions, but obviously post-COVID, there's a lot more, using web technology, which is great. And so, and in that kind of workshop, it's a whole day or two that people split up into groups, and there's well-published methods to come up with the top 10, and it's all by consensus. And those top 10 are then published and available to everyone to look at. And then the real work, if you will, starts, where you have to try and take that to research funders and say, hey, look, this is what people who live with the disease, this is what people who have to treat the disease want to find out. These are important questions, and we need to allocate funding to researchers who are willing to answer them. We have to do the work. And so this is, I'll tell you a little bit about our experience conducting the Canadian MDS Priority Setting Partnership with AMAC. So we formed a steering committee. It was formed of 7 members. Gwen Berry, who is a person living with MDS and part of AMAC's board of directors. She graciously lent her expertise to us. Cindy Anthony as well, who's familiar to many of you as the executive director. There was Hayden Liang, who at the time was the vice chair of the AMAC board of directors. And then there were 4 hematologists, myself, Dr. Mitchell Sabloff, and Dr. Rena Buckstein, who are all MDS subspecialists, and Dr. Lisa Duffett, who is an academic hematologist who also works at the Ottawa Hospital, but her specialty is blood clots and more classical hematology, but she is very interested in patient engagement. And so she was there as well to provide us kind of not an MDS specialist hematology perspective, which is important. So we had a few meetings, we agreed to the terms. Our steering committee, everyone was very generous with their input into our website. We created a website and the survey, and AMAC, as well as other colleagues, helped to pilot the survey to make sure that everything works well and people don't have trouble understanding the questions. And then from there, we reached out to, form a broader partnership. So AMAC kind of reached out to their other organizations, like the MDS International, for example, and others. And then myself and my colleagues all reached out to other organizations, for example, Canadian Association of Nurses in Oncology, Canadian Association of Pharmacists in Oncology, the transplant physicians, general hematologists, and community physicians. So we really tried so that everybody knows that we have this survey open, and please participate, because we want to hear from everyone, not just super duper experts in something. So the survey was posted online on a bilingual website, and it was designed specially for this purpose. It was part of the Ottawa Hospital Research Institute. We kind of, said what this was about, and the survey was open from September to December of 2018. We also knew that we needed to do some extra advertising other than just emails and spreading the word. So we advertised with posters in the hematology clinics in the Ottawa Hospital. We also took out some Facebook ads. We took out some Google ads, which targeted people who were looking for information on MDS. We also asked all our partners to spread the word on their social media channels, as well as share direct email with their members. We did have a paper version of the survey available, but nobody requested to fill that out. And this is kind of an example of what the Facebook ad looked like. And there was one that was similar for clinicians that we shared, and it was in both English and French. Any questions so far? I just want to make sure that people feel very free to interrupt me and ask questions or anything if it's not clear, because I'm not gonna need the whole hour just to present slides to you. So the more interactive, the better it is. So please feel free to interrupt. So in terms of the results of the survey, for people who have a lived experience, so people who have MDS or their loved ones, we had 114 people who started to answer the survey. So at the beginning of the survey, we had some kind of demographic questions: how old are you, where do you live, etc. What language do you speak, etc. And so people started to answer it, but of the 114, only 48 actually gave us a research question. For clinicians, it was similar. 49 started the survey, but only 15 actually entered a research question. Most of the surveys were in English, and I'll show you the actual data in a minute. They were submitted by people identifying as women, and most of them from large urban centers in Quebec and Ontario. And there was a big drop off in participants from rural areas. So people from rural areas would start to answer the questions. And then once we got to what questions do you have for researchers about diagnosis, about prognosis, about living with MDS, etc., it just dropped off. People wouldn't answer. And non-hematologist healthcare providers, they would start. So we had a few nurses, a few pharmacists, but they wouldn't submit questions. Despite that, we had, people actually respond. So, and you can see here, I want to show you this because I want to show you that this column is important because you see who we reached, which tells you that we were able to spread the word. And this here are the numbers of people who actually put in a research question. And this is very important because it tells us that maybe there are barriers that aren't just who hears about the survey, but who feels empowered to actually submit a question to the survey. How are people interacting and relating with something like that? So if you look here, we had about 69 people, so 60% of people who started to answer the questionnaire were a person living with MDS, and 36% were a friend or family member, and then 3.5% didn't want to tell us either way, which was fine. There were no mandatory questions on the survey. And really, it kind of stayed that way, but mostly it was 66% of people who actually entered a question. Likewise, it was mostly English. We only had 6 people even attempt a French survey. The median age was kind of 64 years and 67 years old. And we know that the age of diagnosis of MDS is on average 70 years old. So that's not that surprising here. 75 people identified as a woman, so it was 65 or 66%, and that carried through. So for some reason, women are more likely to answer these surveys and more likely to actually submit a question than people who identify as men. We were able to reach nearly every single province, but no territories. And however, a lot of provinces, people from many provinces didn't answer or didn't submit a question. So here we see Manitoba, we had 2 people attempt it, nobody submitted a question. Saskatchewan, 2 people started and then only 1. Alberta really dropped off here. British Columbia, 16 people started, only 6 submitted. So for some reason, we were able to get most questions from Ontario and Quebec. And although you could say, well, most people, those 2 provinces account for lots of the Canadian population, it's not fully that, because we just have, some places people started, but they didn't quite finish it. So it gives us a lot of food for thought of, moving forward, how do we try and fill in the gaps so we can hear everyone's point of view? Likewise, most people who actually submitted questions to us came from large urban centers, so large cities, some from medium. And so we know that we reached people who live in rural communities, but very few of them actually submitted a question at all. And small urban as well. And again, that's important because we want, obviously people living in urban areas and in rural areas may have very different needs in terms of care delivery, for example. And we did ask about that, or what type of care they are able to receive. We know we live in a vast country with lots of differences in how healthcare is delivered and accessed by people. Not surprisingly, we had most of the questions came from people with low or intermediate 1 MDS, with intermediate 2 and high being less. There's, and I can think of many reasons. Some people didn't know, and that's totally fine. And a few didn't answer. And we know that people with higher risk MDS are, maybe a little bit busier with their treatment that's more demanding. Maybe they're more tired. As well, 2/3 of all people living with MDS are living with lower risk MDS. So things to kind of think about. And then we wanted to know the type of setting where MDS care is being received. And that's to help us understand, are these questions unique to people who are getting their care in smaller communities and non-academic or community hospitals, et cetera. And we did the same thing with clinicians, and you can kind of see that nurses and pharmacists started to answer the questions, and only 1 brave nurse submitted an actual survey with questions in it. And again, for some reason, we had that man-woman split that's very similar to people living with MDS. And most, again, here, practitioners were from Ontario. We had a few from Quebec and basically nothing else. 1 person from Alberta. And a few said, no answer, didn't answer where they were from, and there were 3 of them that responded. And again, there's kind of a dominance of this large and medium urban center, and most are from academic centers, a few from community hospital practice. And you might ask, like, why did you collect all of this information before you even get to what people are asking? And it's important because when you think about prioritizing, it's almost like you're voting for a research question. So, it's a political thing, even though we don't think about it that way. When you're presenting priorities, you will ask, whose priorities are these? If we're going to put money and effort into that, we have to make sure that we are hearing from the people who represent the full spectrum of those affected by MDS. Otherwise, we continue to propagate kind of these gaps. We continue to miss the needs of certain populations. We continue to use the same methods that reach people who we easily reach anyway, and leave out those who we're not hearing from. So just like in politics, when you keep doing things the same way over and over again, you get a large group of the population that feels disconnected, disenfranchised. The same thing here. If you don't check your methods, if you don't check your biases as a researcher, as a physician, etc., then you're going to end up, leaving out a big group of people who, as far as I'm concerned, it is our responsibility to reach and make sure that we are answering their concerns as well. So we received a large proportion of anecdotal submissions, which means that, like I told you, people did not answer their questions as a researcher would, which is fine. And we did a big review of the James Lind Alliance method itself, and this is common. And in many of these PSPs, if you don't know that you're going to get anecdotal submissions and you're not ready for it, and you don't have the expertise in this method, people just discard them. But we really did not want to discard anything, because people have poured their thoughts and their time into this, and we wanted to, if at all possible, even if it's someone's telling us a story of their experience, we need to take a really deep look at their experience and say, okay, what are some of the questions that they are trying to tell us? What are some of the gaps that they are trying to point out to us from their experience? And I think that enriched us. I coded it. Basically, I went through and I said, okay, I think this has to do with communication. I think this has to do with transfusion. This has to do with, whatever genes it is. And then somebody else verified it, which, is a standard sort of way. And we, like I told you, we went through all of the anecdotes that people submitted. And if it was at all possible, we mined them and we grouped them, and we wanted to get them. Overall, even though we had, relatively 68 or so people who responded, we got 203 research questions submitted, which is really, really great. And they fell into these big categories that I'll tell you about. And I want to point out here is that the blue line is people who live with lived experience. So people who have MDS or their loved ones, their friends and their family. The orange is the clinicians, who we know from showing you the table are mostly hematologists. And then the total. And I show all these 3 because you're going to see that there are some places where physicians or hematologists, for the purposes of this talk, and people with lived experience, they have similar priorities or similar questions, and places where they don't. So this is kind of the big category. So stem cell transplant, there was a few questions about it, not that much. The social burden of MDS people did ask about, what about transfusion practice? That was kind of similar. Treatment evaluation. So that means, does this treatment work? How do we know it works? Or does this one work better than the other one? And here the clinicians were quite a bit more interested, and it's all in proportion of submissions, because numbers wouldn't be fair. We had different numbers of clinicians and people living with MDS. Symptoms, people with lived experience were much more likely to ask us about symptoms of MDS, right? So nearly 25, so it's 22.5%-ish. Versus only 10% of hematologists. Access to care was one that both groups were really interested in. And communication as a group was actually also something that they were both interested in, although, more of the patients. So about 12.5% of questions we got were from patients were about communication and outlining communication problems in MDS, which is, very important. Then alternative therapies, there was a few questions about that, included things like herbal stuff, the role of things like marijuana, supplements, etc. Living with MDS was 20% of all submissions from patients, and about a little over 15% total. So people want to know how they can live better with MDS. How can they manage their symptoms? How can they maximize their health? Cytopenias, so low blood counts, a few of them. Diagnosis, it was many more of the clinicians were interested in kind of diagnosis questions versus people who live with them. Hypomethylating agents, those are things like azacitidine or Vidasa and Inqovi. People wanted to ask about. And then prognostication, again, clinicians wanted to know about it, and then the biology of the disease. And we break them down even more. And I'll show you here, and it's kind of important because I showed you the big class of things, but I want to show you what patients really want to find out about. They want to know what to do about their poor appetite. They want to know specifically about fatigue. How do I deal with fatigue? A couple of people highlighted neuropathy as a side effect of treatment. People said, I have sweats. What do I do about that? Communication, like I showed you. And if you break it down like this, communication is the top single question. And that did not go unnoticed, I'll tell you. Holistic drugs, diet, enhanced quality of life, the relationship between blood counts and symptoms. And I already told you that sometimes the fatigue and the symptoms that people have may or may not be connected to their blood counts. Early diagnosis, the causes. So when patients did ask about diagnosis, they wanted to know why they got MDS. Meanwhile, for physicians, they wanted to know how to best transfuse patients. They wanted to know about more targeted therapies. They also wanted to know what to do about fatigue. There were lots of questions about fatigue. They wanted to know how to best work with other clinicians, how to best work with other physicians to make sure that their patients were well taken care of. You'll notice here that patients actually a fair, proportion, so almost 5% of questions had to do with MDS specialty care. And I'm going to share with you one of the anecdotes that we had that'll give you a flavor of what people wanted to solve in terms of the Canadian MDS landscape. Physicians wanted to know about end-of-life care for their patients and how to enhance quality of life as well. And then genetic factors, how do we predict who's going to do well on Vidasa or not, and other things, so more accurate prognostication as well. So any questions here, any comments anybody has about those things? Do you think that as kind of a patient stakeholder group, this speaks to you at all? Is this similar to what you would have thought, or what kind of differences do you think there are?
If anybody wants to speak, you could just click the raise hand button on the bottom of your screen and I can unmute you.
Going once, going twice.
Don't see anybody yet.
Okay. All right, well, maybe it's something to ponder, but I would be very interested in getting your perspective on that. If this sounds like something like you're like, yeah, I can relate to this, these kind of questions, or, well, this is really surprising. I would have thought there's an area that's, I'm not seeing here at all. I mean, myself and my colleagues were kind of very pleased to see that there's a big variety of questions that we were, people were submitting. And so even though we didn't have huge numbers, we kind of had enough to go on and to carry on if we can to the next stage, and then target people in areas that we didn't reach and say, hey, what do you guys think about these particular questions? And I'm going to show you an example of a question that I got. And I did black out or censor it because I wanted to protect the person's identity. They identified where they lived, and I didn't want to do that. So when I was diagnosed with MDS about 5 years ago, not much information was given to me except the fact that I might die in 3 years. Why is all the information so secretly guarded by the cancer centers? I have not been given too many details about my illness. I've had to research the illness for myself. Any doctor providing this diagnosis for a patient should be mandated to contact an MDS center for consulting first. We were given very unclear information as well as inaccurate prognosis by the doctor that gave the diagnosis. Would have been far better coming for the specialist from the onset rather than have the misinformation. And so this is an example of something where instead of saying, well, this is not a research question, like clearly the person isn't saying, well, research should look at this. There are a lot of concerns here. And so we said, okay, there's a few questions. One, clearly this person had I would call it a traumatizing experience of how their diagnosis was communicated to them. And they also found that their access to specialty MDS care was not satisfactory. And so what are the research questions that we can extract from this, for example? So we can say, what is the optimal means of communicating a diagnosis of MDS to patients? What factors need to be considered in communicating a diagnosis? How can access to MDS specialty care early in the disease trajectory be improved? Right. So those are kind of just 3 simple questions that can come out of an anecdote like that. And if you ignore it and say, well, this isn't a research question, it's going to take too much work to go through it, then you're losing what people are telling you. So I just wanted to show you that, and I'm hoping that by sharing this, I can break a little bit of the barriers that people might feel when they're answering things like this, where they're saying, well, I don't know what research should answer, because we got a couple of those too, to say, just write about your experience, write about what you think would illustrate something that could have been done better, something that you're looking for answers on and you can't find them. So I've already kind of, gone through a lot of the key findings. We have, a number of limitations. One of them is that we had very limited submissions by rural resident and non-hematologist healthcare providers. And I consider those to be significant limitations that we need to address if we're going to move forward to say, well, here we are presenting you the final priorities of people of basically an MDS in Canada. We also have no evidence that we were able to reach anyone in the territories. So we need to make sure that these gaps are all addressed in later stages of the work. The strength is that despite the limited engagement by certain groups, we had a broad provincial reach, which is good. That tells us that our advertising strategy, our dissemination strategy was satisfactory, at least in that sense. We were able to do a very deep analysis of the data set, and that was a richer data set than most of what is published out there on similar PSPs, which is over 100 of them. We had good collection of a broad range of research topics, which we can then bring to people and say, hey, this is what we've found out from our preliminary research. Can you put them in order? Which ones are really important to you? And maybe that's a little less intimidating than just giving people 4 or 5 questions and say, like, what research what do you want research to answer about X? We have really good demographic data, which will allow us to properly contextualize the results. So regardless of how limited our results are, we can say, okay, these are the priorities of this group of people. Maybe it'll be us, maybe it'll be a different group, but don't take those to be the holy grail of priorities in MDS research. However, here is what we do know, and we can get started on these while we do a better job on some of the gaps that we have. And that's important because a lot of the criticism of patient engagement and prioritization is, people say, well, how do you know whose voice you're bringing forward? Because a lot of researchers kind of just say, well, I don't know if I reached everyone, maybe I don't have a diverse group, but I never collected the data. So I think we have to collect the data, because diversity and inclusion shouldn't just be words that we kind of worry about after the fact and we sort of say, well, let's just address it. You actually have to put in the work to make sure that you understand your population. You've thought about how you're going to reach them. You've looked at whether or not you have a diverse sample, and then you've gone and actually given it a really good effort, as opposed to just kind of throwing our hands up in the air and being like, well, some people are just too hard to reach, So we're carrying forward a number of initiatives that came from here. One of them is actually a home transfusion project. People, a number of anecdotes within the transfusion thing actually talk to us about how hard it is to get to transfusions, how hard it is to constantly be busy with that. And so at the Ottawa Hospital, we're going to be launching a small quality improvement project to pilot what it's like to move transfusions out of the hospitals. The second one is using smartwatch technology to track people's activity levels, their heart rate, their quality of life, to look at how they're doing in between transfusion episodes. And again, it's a small pilot, but the goal of that is to try and take a step towards individualizing transfusion for individual patients. Some people will do just fine in between transfusions. Transfusions won't make a difference to them. So then the thought is maybe we shouldn't be transfusing so often. And in other people, you'll clearly see that transfusion is helping. And so by kind of learning what to look for, we can eventually get to a point where we can use things like smartwatches and Fitbits and all that to actually predict, okay, this person, or these are the characteristics that will predict how often people need to be transfused, or even in a, down the line, we can say, well, once these parameters change, that person needs to be booked in for a transfusion, for example. I'm also liaising with MDS researchers internationally who are also, starting to undertake research prioritization into MDS in their own countries. Ours was the first. We didn't bring it all the way to completion, but there is some. We've had some challenges in terms of the resources that are needed, and we are looking at ways that we can pool our resources with other researchers internationally to kind of compare and contrast and see what we can learn from their priorities as well. And really, even if we don't completely complete the entire PSP, it gives us a really good springboard to say, all right, here are the things that we can share with the community at large, and that we can say, these are areas in MDS care that we need to be addressing. I want to kind of acknowledge first and foremost all of my patients and their families who are just so generous in giving their time and their effort, whether it's on this particular survey or just chatting with me and my colleagues in clinic, sharing their knowledge and the experience that they have. Both, like I said, within this work of the PSP and also just on a daily basis. You're all the reason why, we want to do this work, and truly an inspiration. Dr. Ian Graham, who is a prominent qualitative researcher, he's actually a sociologist who was actually my thesis supervisor while we completed this work, and he is a key figure in pointing out, how do you address inequity? How do you include people? How do you best think about the complex issues that surround, research and healthcare delivery? My clinical colleagues in the leukemia program, as well as my nursing and pharmacy colleagues who provided so much input during the pilot phase and who shared on their social media. OHRI, so Ottawa Hospital Research Institute Communications, who helped us with drafting the advertising and crafting that strategy, as well as the OHRI webmaster for putting up the website and helping its upkeep throughout. We've got still about 15 or so minutes, so I will be very grateful for any questions you guys have.
Great, thanks so much. I'll just unmute people's lines here so they can ask a question if they like. Anybody has a question, just feel free to jump in. I have one, maybe I'll jump in first. You mentioned that communication was a priority both for clinicians and patients. Was that generally around communication between patients and healthcare providers? Was that the concern that most brought up, or was it other avenues of communication as well?
Yeah, a great question. So there were a couple of different facets to it. It was mostly between clinicians, so physicians and the patient. Most of it was around the diagnosis and the prognosis and how to best communicate that. There was also a few submissions that had to do with communication between one physician and the other. So you see your MDS specialist, they tell you one thing, you go to the community, you get a fever, the physician there doesn't understand or doesn't know what it is that you need, or you go in with your blood count that's kind of not quite as low as they're used to it, for example, but you know that you need a transfusion, and having to tell your story over and over and over again every time you end up somewhere different. So those are the two most prominent things. And I'll tell you that there is this like kind of pet project that I have in the back of my mind where someday, but we need some, again, as always, resources and kind of let it marinate really, which is how do we leverage something like an MDS care hub, for example, where people can have all of the information about their disease, about their trajectory, about what treatments they've had, accessible, about their, I need this kind of transfusion at this kind of threshold. And it can be accessible to their clinician, to themselves, and they can give it out like a pin almost to whoever they see. Now there's, that doesn't substitute for good communication of a diagnosis, but I think that it would really help, because sometimes when you're talking to people in clinic, you're just giving them so much information, they're completely overwhelmed. And then you send them off with this booklet, right? And then they're trying to figure out what part of the booklet it like pertains to them. And then they're just waiting for their next appointment. And a few people actually said that. They're like, then you're just looking. And so it doesn't cover everything, but I think that if we communicated it, we put it on the patient's care hub or profile, and then they were able to access it, not necessarily through my chart, but just through like, a dedicated MDS hub that's tailor-made for that. That would be kind of a neat thing. And so that's just one idea. Obviously, we have to do a lot more work in terms of just asking patients in more depth, what was the best thing, what was the worst thing that happened when you were diagnosed with MDS? What are things that you wish they, physicians didn't say, or what do you wish they had said? And obviously, because people have, no two people's MDS is the same. There's going to be a wide variety, but we have to collect some of that information so a physician knows, when I'm going in to talk to this person, here are some of the factors I have to take into consideration. Here's what maybe I should ask them before I launch into my explanation, so that I can tailor it to that person.
Mm-hmm. That care hub that you mentioned, has that been tried with other disease groups?
There are some, yes. They are not quite as complex as MDS. And so it's much easier to do. MDS is obviously something that changes over time and is quite rare. But yeah, people do have care hubs for their diabetes, for example, for things like hypertension, et cetera. But those are disorders that are much more common, that more physicians understand. And so that's the challenge. And that's kind of why it has to marinate a little bit, because there's a lot of different moving parts that we need to break it down so we can create it at some point. I think there's a chat question. Where do we go from here? Are there any research or studies being done in BC? I can't tell you specifically in BC, but our goal is for all of our work to, be open to our colleagues nationally. And so, as a first step, like I said, we're doing the home transfusion pilot. We're working on the smartwatch. The results are getting ready to be submitted for publication of this survey. I am part of the MDS CAN kind of registry. So I know that there are colleagues in BC who very much care about this and would be open to it. It's just a matter of getting the results out and actually saying, okay, what is our next step? And maybe different groups will take up different ones. I don't have any interest in hogging the findings. These are your answers. So they're going to go back out into the public domain.
And there's also a comment here. Can you see that?
Yeah. Converting the US blood numbers to Canada's. Yeah, so converting US blood numbers to Canada's, if you're asking specifically about the hemoglobin, you just multiply the US ones by 10 for the Canada. So like a 9 in the US is 90 in Canada. So you can also go the other way. I'd like to know my IPSS levels without having to ask my doctors. There are online calculators that you can type. You do need some information about from your bone marrow results, about your blast count and your cytogenetics. You also need to have access to your labs at the time that bone marrow was done in order to calculate it. And I guess that brings me back to this Care Hub is, if I had a magic wand, I would just make it so that you would have a unique identifier and you could go online and go look at it and see what your IPSS is. You could also show it to your family when you go home and you say, I just had a meeting, I got diagnosed with MDS. A lot of blood work. Yeah. So they'll ask you on the calculator, it specifically tells you which blood work. Oh, a lot of blood work. Yeah. There's no universal conversion. You'll have to kind of look at it. This is the hemoglobin, creatinine and stuff like that. There are online calculators, and even us clinicians, the Americans have to put it into a calculator to figure out what we're talking about. We have to put it in a calculator, figure out what they're talking about. But yeah, they still use the imperial units for a lot of the blood work, but the hemoglobin is the easiest. The platelets are kind of the same, and the neutrophil count is also similar. Like 900 is 0.9, 1000 is 1, so it's all.
Jim, I just asked, you can unmute there if you want to ask a follow-up question. All right. Okay, well, I think we're at the end for questions and also at the end of our time. So I just want to thank you very much, Dr. Christou, for the presentation. Really informative, and we look forward to hearing more about the outcomes of your work in terms of more research going forward. And thank you to all those who participated. Just want to remind you, we still do have some webinars happening during the summer. If you're interested, you can find out about those online. And we are also still hosting monthly virtual patient support groups. So you can also see those on our website, and you're free to join anyone from across the country. You don't have to join the one in your area if that's not convenient for you. And we have a message there, a big thank you. So thanks again, Dr. Christou, and have a good day.
Thank you all. Have a good one. Bye.
Thanks, everyone. Bye-bye.